All right, well, you heard her. You better stop by and talk to her. But we do appreciate everybody being here. This is what we do, and the reason we're here is not only for Mary Ann, it's for all of you as well. So we appreciate you all being here. Dr. Maluccio, I know we're a little early, but are you ready to go? All right. So our next speaker was originally going to be our first speaker, but somebody, I'm not saying it's me, messed up the agenda here. So Dr. Mary is here now. So please welcome Dr. Maluccio.
Okay, awesome. Okay, hi, Mary Maluccio. I run the program in New Orleans. So these disclosure sides that we have are to tell you that some of us will function on advisory boards, get paid for giving advice or things like that. And then some of us tend to sort of shy away from all of that. So no disclosures means that I don't get paid to give talks for different drug companies. Now, I do have one disclosure, which is that you're getting the PRRT talk from the surgical oncologist, but if you've ever met radiation oncologists, they tend to be some of the most cerebral, like way out there. So you'll probably understand it a little bit better coming from a surgeon. So this is a surgeon's version of a PRRT talk. So the objectives, what I hope you will be able to glean from this talk after around 20 minutes, is that there are sort of definitions that we will use that will compartmentalize people, and that it will weigh into how we make medical decisions and put sort of treatment expectations in perspective. Since this is a talk on PRRT, I want to explain how PRRT is one of several treatment options. I think we were trying to get that message through, which is none of these treatment options are mutually exclusive. To better understand what variables may weigh most heavily into the medical decision making around PRRT, what data best supports PRRT, and what are the current expectations, and then the ongoing question of alpha versus beta PRRT and some of the clinical trials. So the definitions that are going to be relevant to some of the talks that we had this morning, and then maybe the talk that Rob Ramirez will give after me, is that when we are looking at cancer in general, whether or not it's neuroendocrine cancer versus almost any other cancer, is that in medical speak, we do define how we approach things so that it can set expectations not only on our end, but obviously for you guys as patients. So when we say that something is being done with curative intent, it means that we are trying to eliminate this problem for you for the rest of your life. But we know that you can do something with curative intent and still there will be a risk of recurrence depending on the biologic pathology report, node positivity, and things like that. So that from a surgical perspective, when someone is diagnosed with limited disease in the small bowel mesentery, all measurable disease is being removed with that operation is being done with curative intent in hopes of eliminating this as a variable in your life. And so breast cancer, colon cancer, prostate cancer. So there are a lot of things out there where we will be doing something with that intent. And that is really relevant to how we make decision makings in a lot of cancers. It is a little bit less relevant in neuroendocrine because, as Cameron said, there's a really high likelihood of micrometastatic disease and the development of metastatic disease over what can be a very long life. But that's one of the burdens of neuroendocrine, is that ongoing risk, even when you have a case that removes all measurable disease, that ongoing risk of something happening over the course of your life. Palliative intent means that the procedure, be it a liver-directed procedure, a PRRT, a surgery, or even chemotherapy, or somatostatin receptor analog therapy. Palliative intent means we are identifying a problem. We are identifying a symptom or a burden whereby the treatment has less to do with longevity. Doesn't mean that palliative intent doesn't lengthen your life. It's just that the intention is to palliate that symptom, palliate bleeding, palliate obstruction, palliate carcinoid syndrome, whatever it is, so that we can then win if we do the intervention and then you ultimately have less symptoms, live a better life, better quality of life, then we have met the goal of palliative intent. And then obviously, I think there's going to be a lot of times when if someone has severe diarrhea, for which then they have electrolyte disturbances, for which then they need IV fluids, and we give them something like telorostat or liver-directed therapies, or we drive their serotonin levels down and their diarrhea gets better and they don't have those fluid and electrolyte disturbances, well then yes, we are absolutely likely changing the course of a longer term goal. So, and then prolongation of life is how we treat most cancers, which is that you will have a lot of variables that will predict whether or not you will have a neuroendocrine specific event or a breast cancer specific event over X number of years. In some cancers, we do it over 5 years. In some cases, we do it over 10 years. And neuroendocrine is sort of a lifelong thing because weird things can happen. So that is when you are giving a treatment, PRRT, chemotherapy, surgical cytoreduction, where when successful, that patient will live longer than anticipated were we not to have done that intervention. So in neuroendocrine, it's not that we never live in the realm of curative intent, it's just the risk remains of a neuroendocrine specific event over that long life, but we very much live in the world of palliative intent and prolongation of life. So treatments are not mutually exclusive. I just put all of them down, and then I bolded the ones that I was asked to sort of touch on, but that I do like, and in answer to the question from the audience that was about getting differences of opinion from different subspecialties, I do like for patients to understand the menu of options, even if there is a clear winner in that case of what option would be best under those circumstances. At least you can understand why we aren't choosing PRRT or surgical cytoreduction at that juncture. But as the panel went over, is that just because we're not picking it then does not mean that we won't be looking at it down the road, be it 6 months, 1 year, 2 years, even 5 years down the pike, when maybe we have a better understanding of the biologic behavior. So the things that I was going to touch on were predominantly PRRT, and then obviously how that relates to somatostatin receptor analog therapy. And then I will touch upon actually very quickly, since I think Marsala and Cameron did a great job looking at IRE, and then everyone pretty much mentioned histogens. So my red hat, this is my analogy that I will give on most of my talks that I give, is that neuroendocrine is very much like looking at parking spaces, except it's not a parking space, it's a receptor. And for Garima, it's a red hat. And so really a lot of what we're doing is we're trying to target a receptor. And a lot of the treatments that we do are pretty much a vehicle that is directing therapy to that parking space. And when you're reading out that PET report and you're looking at that SUV number on there, that's pretty much telling you the density of parking spaces that are available on that tumor cell. So ultimately, if you were to just think about sort of naked parking spaces, this Walmart parking lot right down here, is that a tumor that is unsuppressed at all is going to have a number of open parking spaces or open receptors for which then we are trying to bind that therapy, and I'll explain how that functions in the context of PRRT. So when you trigger the neuroendocrine system the normal way, meaning you eat physiologic stressors, food stressors, temperature stressors, stress in general can trigger these. The natural chemicals in your body, a lot of them, whether or not it be serotonin, gastrin, or whatever. So those are going to go up, and those are going to be cars. So those are cars, the natural cars that are then searching for another parking space so that then they can stimulate that cell. And so obviously one of the survival mechanisms they have is that you will have these triggers, your natural chemicals will go up. Those chemicals are cars searching for parking spaces, and then the cells then continue to trigger. And unregulated, meaning when it doesn't turn itself off, well, then that's the symptoms associated with what we call carcinoid syndrome. So if you were to look at somatostatin receptor inhibitors, or really somatostatin receptor analogs, because in general, analogs mean they are competitive agonists. They look exactly like the real thing, but that they don't stimulate the cell the way that normal chemical does. So somatostatin receptor analog injection therapy is a standard of care for any patient with measurable disease that is somatostatin receptor avid, meaning it's hot on a PET scan, meaning that you've got the parking space or the target, and therefore in giving this drug, you are like injecting you with a bunch of little cars, these analogs. They're searching your entire body for a parking space, and like a police officer putting a boot on the car, it's trying to cripple that cell, as Grima said. It's trying to cripple the cell, keep it from spewing out the stuff that give you carcinoid syndrome, but also mess with the mechanism by which it divides. And somatostatin receptor analogs have been a standard of care and are associated with a delay in tumor progression over time. And although it took almost 15 years to show a survival benefit, it is associated with a survival benefit over not treating someone at all. So somatostatin receptor analogs are pretty much, if you got enough cars clogging enough parking spaces, then the normal chemicals will have no place to park, so that you can get a lot of palliative intent. You can get a lot of symptom control with just those injection therapies alone. And you can get a lot of tumor control just by having enough drug blocking enough of those receptors. And it can be all that people need for years, if not their entire lives. So the goal of treatment with a somatostatin receptor analog is predominantly to delay tumor growth over time. So then if you were to look at PRRT, so using that same analogy, then the PRRT is pretty much taking the same car and you are going to infuse it like IV fluids. I have a slide for that. But that you are putting on top of that car, like a taxi cab, you're putting a radiation particle. And that vehicle, same car, is going to drive over your entire body looking for the same receptor. And ultimately, it binds irreversibly to that receptor, and it delivers the radiation to the source. It's called a brachytherapy. So it is therefore clearly relevant, just like somatostatin receptor analog therapy is relevant to somatostatin receptor avid or hot tumors. This is very relevant to tumors that are somatostatin receptor avid, but not as relevant to patients that have lower SUVs on their thing, because if you don't have the target receptor, you do not want to be sending in radiation to be having a joyride all over your body, not being able to find a parking space, because then you can get a lot of systemic toxicities. But that it is associated with a significant improvement in progression-free survival compared to somatostatin receptor analog injections alone. So if you were to just think about the car analogy, is that this is the car, this is the taxi cab light, I call it a radiation particle, sitting on top of it. It is sitting onto this receptor, and then it's going to stick onto this receptor, and then the cell is just dumb enough, but that's how cells work, is that just dumb enough to, like a whale, it eats the whole thing, not realizing that it's just eaten a poisonous eel. So and then it damages the DNA within the cell, and DNA damage then is what leads to potentially at least the crippling of the cell, if not the killing of the cell. And I'll go over slight differences in that between alpha and beta particles. So then when you're getting Lutathera, it comes as an IV fluid. Okay, so here you've got this radioactivity, you got the car with the light on top, and it goes in infusion, it goes in through your vein, and it's ultimately killing it at the cellular level. And then you'd say, well, sorry, I'm going to go back. So then you'd say, well, then how do you know if you are just infusing it like IV fluids? Like, how do you know where it's going to go? Well, because the PET scan that we use, which is a copper PET, so those are the curium people outside. So a copper PET uses the same exact attack car. So pretty much I call the PET scan a car with a pizza delivery light. I call PRRT, you take the pizza delivery light off and you put the radiation particle on, and you know where it's going to go because you're using the same car to deliver the therapy. And in Europe, when they initially came out with all these PRRT trials, they would usually do a PET scan like right after they delivered the therapy, and you would almost have them interchangeable, meaning the diagnostic PET scan, which is the copper-64, gallium-68 PET scan, and then you'd have the Lutathera, the lutetium-177 PET scan, because everything is just radioactivity, and those would be interchangeable. So we felt really comfortable that we understood how that was going to distribute. And yes, it will often distribute relative to the SUV. Those are the hotness numbers on your PET scan. But what is kind of important about PRRT is you need to have that PET scan beforehand, because neuroendocrine can go to really weird spaces, like the muscles in your eye, or some of bones, or areas where, in order to understand why someone may be having some side effects related to PRRT, you'd want to know that, oh yes, that side effect is because the PRRT likely went to that area. The eyeball is the one that is probably the most problematic. So we get the PET scan before we give the radiation, so we can understand the distribution, so we can explain any weird symptom that someone is having after the delivery of treatment. And it's given 4 times over around 8 months. And that is predominantly because of the heterogeneity of the disease. You'll have some tumors that are hotter, they have more parking spaces, and because you can't control where it goes, it's going to go, kind of get sucked out of your bloodstream, kind of like a magnet. It's going to go where it's going to go. And so you can't just say, oh, I really wish you had gone there, because the person would have really appreciated having it go to the bones as opposed to the liver. But that if by giving the first dose, then it's going to distribute, and you'll likely get rid of the hottest ones. And then they're kind of in DNA damage, which takes a long time to attempt to repair. And then the second go around is going to get to the next hot thing. And then the third go around will cover the next hot. And so you will ultimately deal with the heterogeneity over the course of the 4 treatments. And so the plus side of PRRT is the fact that you can, with one strategy, treat multiple areas all at the same time. The downside of PRRT is you cannot control where it goes the same way you would a liver-directed therapy or a targeted radiation that a radiation oncologist gives to a bone met or something. So the variables that weigh heavily into the decisions about PRRT are going to be the pattern of distribution of the disease. So if you were to look at the trials that initially came out in PRRT in Europe, it was really for people that had relatively widespread metastatic disease. We call that multi-organ site involvement, meaning bone, lymph nodes, liver, maybe small bowel or pancreas. And that word actually sounds a lot worse than it is. It's just the challenge of dealing with multi-organ site activity is the fact that surgery can't affect the bones. The surgery that you do in the belly doesn't affect the stuff in your chest. And so PRRT is really focused on people that have multi-organ site involvement. So then you say, well, how do we decide on PRRT versus something like liver-directed therapy? Well, PRRT in Europe has probably been around for 20 plus years. In the United States, it's probably been around for 15, maybe 12 years. And so I think for those of us that live in the world of neuroendocrine, we will often use some of these things in a very creative way. So for example, our program, and probably Vanderbilt as well, will use liver-directed therapy because it's got a really high response rate. It can totally take out a bunch of parking spaces in the liver. And when you infuse things intravenously, the liver is kind of the hungry hippo. So if you've got disease outside the liver and you've got a lot of disease in the liver that's going to soak up all of your dose, we will often treat with liver-directed therapy, and it's almost like diverting the cars, almost like a diversion or a detour for a traffic jam. So that's where some of the creativity, and those are the types of things that we discuss at Tumor Board. Like in this case, where do we think this PRRT is going to go, and what can we do in order to try to manage the totality of the disease in someone with multiple organ sites? So you got to have the SSR avidity on PET imaging is because you've got to document that you have the receptor. In general, I'm going to show you some data that doesn't require progression, but in general, it was not used frontline initially at diagnosis, but it was done when someone had progression. And that progression had to be, despite what we felt was adequate dosing of the injection therapy. So there are some medical oncologists that will start with a 10 or 20 milligram of sandostatin and then dial it up as the disease maybe grows a little bit, but that we don't want to sell something like somatostatin receptor analogs short because they are a standard of care and have been around for a really long time. And so we do want to make sure that someone is having the disease, they almost have more parking spaces open. And so the somatostatin receptor analog injections are just not enough to control that disease. And then in general, like I was alluding to, is that we would like to know that surgical site reduction, for whatever reason, is not considered appropriate. And that has a lot to do with the fact that operating on someone after PRRT has unique challenges. So the expectations of outcome with PRRT, so this is the NETTER-1 trial. This was what we were really just trying to corroborate some of the data that came out of Europe. The FDA in the US doesn't allow us to just say, oh, those guys did it, can we just do it here? No, you have to do it here too. So we did the NETTER-1 trial, and so the two groups, and I'm going to explain why we did it this way. So the two groups were that we were going to take this PRRT that had been used in Europe for probably close to a decade by then, with the expectations of response and durability of that response over time. And we were going to compare it to somatostatin receptor analogs, but we weren't going to compare it to just the standard somatostatin receptor analogs, because in general, these patients had progressed despite being on that drug. So that wouldn't really be a fair fight. So the way I describe the somatostatin receptor analog arm of this trial is that it seems logical that if you have a drug and the concentration of the drug, you have enough cars blocking enough parking spaces, or you don't have enough cars blocking enough parking spaces, send in more cars. So we called that dose escalation. We would just jack up the dose of the somatostatin receptor analog. Well, that didn't help. So even though it sounds really logical for whatever reason, it didn't really help, although it may help in some patients. But generally, that strategy was something that we were very accustomed to. It was not really satisfying, and it was associated with a higher side effect rate. So they compared it to the jacking up the dose of somatostatin receptor analog, doubling the dose compared to PRRT. And when you see these curves right here, this is just the progression-free survival, or the rate, the time interval before the tumor started growing. And when you have these two lines that are kissing like really close, it usually means that there's not really a significant difference. They're both very similar. And then you got to remember the similarities given the heterogeneity of neuroendocrine is that you really want those lines to be far apart. So this, if you were to think about this as a race, oh yeah, PRRT won, hands down. PRRT's way up here. It took way longer for the tumors to start to grow after PRRT than if you just doubled the dose of somatostatin receptor analog. I'm not even sure they necessarily, I think that was probably a little bit better than the European data. I don't think they necessarily expected to be so wide, but so therefore, when you are sitting in your doctor's office and someone's saying is, hey, I'm not sure that the somatostatin receptor analog is enough, and these are the things that we have to do. Oh yeah, this little experiment they did, PRRT hands down won in those patients. So the salient points and the things that I wanted is that when you talk about response rates means that you can see from scan to scan that something changes significantly. It either disappears or shrinks. Well, really, most of the benefit of PRRT was in the ability to hold something in check. We call that stable disease. Hold something in check for X amount of time. And so clearly it was very good at holding it in check. But the response rate, and this becomes relevant when I'm talking about alpha particles, the response rate was actually pretty low. So so for a patient investing in a treatment and then you say, oh, good news, your scan looks the same. You'd rather say, oh, good news, I don't see like a bunch of things that used to be on the scan. That does not mean that the treatment did not work at the cellular level. It's just that we had to sort of just, accept the fact that we weren't going to see these dramatic changes after beta PRRT. So the salient points to this initial paper, which is ultimately what led us to get Lutathera through the FDA, was that most patients were low grade meaning G1 or G2 when you looked at or when you listened to Garima's talk. So low grade, they tend to have high receptor density, and so therefore there were a lot of parking spaces for that treatment to bind to. Most of it was small bowel. So therefore the poor pancreas people are like, well, is that relevant to me? Because this was all, small bowel. And then the patients had progressed despite SSRA. That's relevant because now the PRRT people would like to see it move up into frontline therapy. There was a significant improvement in progression-free survival, but you have an overall survival for you guys that live a long time, oftentimes will not sort of call out of these tests. It does not mean that it doesn't change overall survival. It just doesn't mean that there was enough patients followed for long enough time for them to prove that point. So PRRT is not necessarily given in the headspace of overall survival. It's really keeping things in check, but that does not mean it's not associated with an overall survival benefit. It just wasn't tested for that. So then you can imagine that the PRRT people were like, well, if that works, can we just push it up into the first line, meaning treating it earlier in the course of the disease? Because maybe we're getting kind of the people that are the bad actors, even though I don't think that's a rational interpretation of what was happening. But so they were trying to push it up. And so the same PRRT company then did this. It's called NETTER2. And they were trying to say, what if I were to give it before someone has gotten somatostatin receptor analogs or before they've had it any sort of progression, so that you didn't have to meet some fork in the road where we were changing our treatment options. And you can see the graphs are also, far apart, which is quite good. Now you have to remember, this is still comparing it to the double dosing of somatostatin receptor analogs. So it's not comparing it to the people that got PRRT later. It's just that they started to give the PRRT earlier. And why this was so exciting, even though I think there are programs like ours that's a little bit reluctant to embrace it frontline because of some of the consequences of giving other types of therapy after someone's had PRRT, at least there is data to support it. So I want people to know that if someone is coming and saying, your radiation oncologist is saying, I think PRRT is reasonable, just make sure that you hit all the other points like multi-organ site involvement, or you can't meet the surgical cytoreduction endpoint or whatever it is, so that you understand that the data is there, but it's relevant to your case. So what was actually, though, neat about this was that their response rate was a little bit higher, okay? So also surprising to those of us that were not expecting it to be that high. So the response rate is a little bit higher when given up front. Maybe that's because the patients had sort of been suppressed for a really long time before they got PRRT before. So a lot of questions on how can something that only had a 17% response rate when you gave it initially, now you're given the same stuff, and now you're saying that, oh my gosh, it's got a better response rate. But what's also important is that they included, actually, more than half of the people had the pancreatic neuroendocrine. So now all of a sudden we at least had some evidence to say this is not just a therapy that is good for small bowel metastatic disease, but that the metastatic pancreatic neuroendocrines were also relevant. They also focused on higher grade. So Garima talked about the different grades. In the well-differentiated category, we have G1, G2, G3 well-diff. That was what this was limited to. But that 65% of them were in what we called the higher grade 2, Ki-67s of greater than 10%. So if you were to compare that to the initial study, those were the vast majority were like the G1 low G2s, less than 10%. So kind of apples to oranges comparison, and yet we would have expected this group to not do quite as good, and yet the data was there. So they were very exciting. They just presented this last year. And so it has raised a lot of questions about the timing of therapy over the continuum of a long disease. And this was really the first thing to come out in the US that would say, hey, maybe we shouldn't be waiting necessarily in all patients. It could very well be relevant in patients before they have shown signs of progression. So then alpha particle PRRT. So why are we all jazzed up about alpha particle PRRT? This is going to be another example of where alpha particle PRRT has been available in Europe for probably at least 6, maybe up to 10 years, they were using it kind of in combination with betas and alphas. But the difference in alpha and beta therapy is that radioactivity is about excitability. So alpha particles have a tight range. As Dr. Boudreau says, it's like a better drone with a stronger bomb. And so your ability to target it with higher energy or more potency is more effective in alpha therapy. So you get minimal damage to surrounding tissue. It's got what's called a higher linear energy transfer. So the energy that's transferred in that, destroying that cell is this. So it's got increased localized toxicity with not any more damage to the surrounding tissue. And it's got a double-stranded DNA breakage. And so when you have your two strands of DNA, and there are certain things, chemo or radiation, that will damage the DNA with a single break. The problem with a single break is that we have DNA repair mechanisms that help us survive this world that we live in. And we are exposed to all these things that cause this DNA damage. And then our cells have the ability to repair it using DNA repair mechanisms. Double-stranded DNA decreases the cell's ability to survive that DNA breakage. So if you were to choose, would I rather have a cancer cell get double DNA breakage? Sure. Would I rather get my muscle cell only to get a single DNA breakage? Yes, because that's what would allow you to recover from whatever injury. And then there is this potential abscopal effect. And then why I want to bring that up is because there is a lot of talk about immune therapy. There's a lot of talk about immune response to therapy. And so alpha therapy, unlike beta therapy, has a little bit more data to support it having then this secondary immune response. So these is just a thing, if people were going to get copies of these slides. The difference between alpha and beta particles is pretty much that the ionizing effect, this is really the thing that matters, is that the ionizing effect is super strong. So it's a tight window, better drone, stronger bomb. So I also wanted to define for you different definitions, because in neuroendocrine, there may come a time, and in a lot of rare cancer diagnoses, clinical trials are often giving you access to drugs that are not yet available through the FDA, and a lot of PRRT and alpha PRRT is only available on clinical trials. So why don't I give you the little primer in clinical trials? So clinical trials are not just that it's unproven. It's actually, you could have a therapy that is 100% proven in breast, has a lot of relevance based on something in neuroendocrine, but we may need a clinical trial to better understand how it fits in with neuroendocrine. So then you have to take this drug off the shelf over here, and you have to say, God, it makes so much sense to use it over here, but that we can't just necessarily willy-nilly do that. We have to then look at it in the context of patients. So what's super important when you're discussing clinical trial with your doctor is that there are phases of clinical trials, and it's really important for you to understand what phase of clinical trial are you kind of signing up for. So phase 1 clinical trials may or may not be entirely targeting neuroendocrine. A lot of the neuroendocrine ones are, because they are being run by neuroendocrine specialty programs, and so they are kind of like the drug discovery type trials. But you got to start somewhere, and you can't go from a rat to clinical care. So you will have preclinical trials where we're trying to understand how it functions in a cell level or in an animal setting. And then at some point in time, we're going to have to put this thing in humans. So phase 1 trials are going to be first in human use trials. There are going to be new drugs that have never been used in neuroendocrine before, but for the most part, we're trying to understand the dose of the drug that is appropriate. We're trying to understand the safety of the drug in certain patient populations, age groups, people with other medical conditions like kidney problems. And so phase 1 trials are truly experimental, meaning that you are not entering that trial because there is necessarily an effectiveness. Doesn't mean it won't be effective, but that is not the goal of the trial. And I think that especially when you live and work in certain parts of the US, there are a lot of patients that will go into something like that thinking that they're getting a really novel therapy. And in their mind, they're thinking that in taking this therapy, it is going to help their thing, but that's not even the goal of a phase 1 clinical trial. That's why usually the phase 1 clinical trials are in people that have already gotten standard therapies, and therefore they have already reached the fork in the road where trying this new therapy is as reasonable as trying like a second or third line therapy. So I don't want to dog clinical trial phase 1s because they are so important for drug discovery. And that's, I mean, at some point in time, somatostatin receptor analogs were first in human, and now they're standard of care. Now, the phase 2s and the phase 3s are actually really relevant to you, because a phase 2 trial could very well have been those initial PRRT trials where there was a lot of evidence to support it in Europe, and we just had never done it in the US. So we already kind of knew it was effective. We already knew it was relevant to neuroendocrine, but we needed to prove it, and we needed to prove it in an American population. So phase 2 trials means that the response to the new treatment is looking at the effectiveness of that treatment. So you'll treat 100 people, and in neuroendocrine, none of those 100 people could be very much the same, other than they'll have a G1 tumor or a G tumor or a small bowel or a pancreas. But that in general, you're still doing it in a man or a woman or a 70-year-old versus 20-year-old. So there's going to be a lot of heterogeneity. So a phase 2 trial is super important for understanding where there are any nuances to the effectiveness of that treatment, depending on the type of patients. And so the small bowels versus the pancreas, that's usually a really strong or important distinction, or the small bowels, the pancreas versus the bronchopulmonaries. So it may be that we aren't necessarily seeing effectiveness in all neuroendocrine, or different effectiveness depending on the primary site. So phase 2 trials are actually very good, effective trials. A lot of the PRRT trials are phase 2 trials. And then phase 3 means there's a lot of data to support it. And it's usually going to be compared to a standard of care like somatostatin receptor analog therapy alone. So if you go out to the Action 1 people, Raise Bio is testing a alpha particle, actinium-225, also has very similar properties, got a longer half-life, so it has some additional benefit of hanging around for a lot longer, and therefore you're likely to get a longer response on any given treatment. But that is a phase 3 trial, meaning that you're going to compare it to some other very reasonable alternative. And then if for whatever reason the reasonable alternative does not work for you, so say, for example, Afinitor, sunitinib, some of the cytostatic agents, chemotherapy, those don't work, then you ultimately do, after a certain point, cross over, and then you are offered the alpha particle. So ultimately, the Action 1 trial is a phase 3 trial testing an alpha particle, actinium-225, against standard of care chemo, which is just the choice between the patient and the physician, and then ultimately looking at the same parameters that have been looked at in other PRRT trials. So then what are the PRRT clinical trials that are available, and what questions are they trying to answer? Now, I was really surprised in trying to prepare this PRRT talk. There are a load of PRRT trials out there. Some are institution specific. You may be able to find them at Vanderbilt. Some are going to be investigator initiated, like Rima said, that maybe she's going to be doing something that is specific to the University of Alabama. But that for the most part, when you're putting together a clinical trial, you are trying to answer a particular question. It's not like we sit there and say, oh my God, wouldn't it be great to do a clinical trial on that? So the COMPOSE trial is looking at beta, a different type of CAR, same beta particle, lutetium-177, and they are trying to see its relevance in higher grade tumors. So a little bit like that NETTER-2 trial with the lutetium dotatate that we are calling this. They're looking at a slightly different CAR, which is this edotriotide. That's just a different type of vehicle CAR. And they're trying to say, hey, how relevant is this as the grade goes from a grade 1, grade 2, or grade 3 well differentiated, which in that study had Ki-67s that I think were even over 30%. So I think it's a really important question, because we were kind of only had tempered expectations. The higher the grade, we felt that there wasn't as much receptor density, and therefore we just didn't feel as confident that the PRRT was going to have the same effect. So the COMPOSE trial, I think, may have completed accrual, but that you could take people with higher grade tumors as long as they were somatostatin receptor avid on PET imaging. The AlphaMedix, which is an Oranomed trial, is using PB212. That's an alpha emitter. It was a phase 2 trial, and they were looking at in patients that were both PRRT naive, meaning they just met that endpoint of progression of disease despite somatostatin receptor analog therapy, compared to PB212. I think that our patients last week were the last 2 patients to complete that phase 2 trial. So I think that the data will probably come churning out on the use of at least PB212, which is just the radiopharmaceutical. And I think what we're going to learn from that AlphaMedix trial is that regardless of whether or not you are giving it in PRRT naive patients, meaning in patients that had never received beta particles, or you're giving in people that had received beta particles, even 6 months, 1 year, 2 years, some of the patients 5 or 6 years previously, so clearly had worked for them, is that the response rate is going to be significantly higher, probably greater than 50% in something that on the NETTER 1 was only 17%, and even on the NETTER 2 was only as high as 38%. So the AlphaMedix phase 2 trial is now sort of complete for accrual. They will have to then go back to the FDA, and with luck, if people are looking for PRRT trials, or that your doctor is saying, hey, I think I got to get your head around a PRRT as an option for you, and you are interested in pursuing alpha particle PRRT, they will likely within the coming months start to open up the phase 3, meaning the next step in getting it through the FDA before it becomes a standard of care, which would mean that programs like ours could use it however we wanted, as opposed to being so limited to the protocol. The Action 1, I just said, so those are the Action 1 people are outside. That's the standard of care versus actinium-225. That's just a different alpha particle. And then I put these up, and you see these NCT numbers, is that all clinical trials, if you were looking at just, even if you're just curious on what's out there and how it would be relevant to your case, even if you're not even in the phase where you would have to consider it, these are all just taken off of NIH.gov. But that if you were to look at, say, for example, this top one, liver-directed therapies go through the artery, the hepatic artery. So doesn't it seem really logical that if you stuck that PRRT, kind of like with Y90 radioembolization, you would go through the artery and you would infuse it directly into the liver for people with liver dominant or liver only metastatic disease? Wouldn't that seemingly be a great thing to do? Well, I think those are going to be negative. So you do something, seems like it's logical, but it must be something about how it gets pulled out of the arterial system versus the venous system, because PRRT given systemically is pulling it out of the venous system. But there are ongoing clinical trials. I don't want to dog it because it seems like a really logical way to give it, but that I think we have very tempered expectations, and I don't anticipate that we are going to be giving intra-arterial PRRT anytime soon outside of clinical trials. So if you were to say combines PRRT with chemotherapy, okay, so as I think Andrew Marsala mentioned, if the chemotherapy can function as a radiation sensitizer, doesn't it seem like if you could then get all the cancer cells to march in one direction, and then you come in with a radiation particle, making them that much more sensitive to it, also seems like a really reasonable thing to do. Well, so absolutely, totally understand where they're coming from on that trial, other than the side effects of PRRT is going to be myelosuppression, bone marrow suppression. The side effects of capecitabine temozolomide is going to be myelosuppression and stuff like that. So that the reason why there are clinical trials is that it makes you just a tad nervous on what the side effect profile of combining those things. So yes, makes sense from a mechanism standpoint, but from a toxicity standpoint, it may be that it's just not going to be enough of a benefit in order to risk some of the side effect profiles. And then if you were to look at the DNA repair, so if you slap on, you do beta PRRT, and then you slap on a drug that inhibits your DNA repair mechanism, well, that sounds logical too. So those are the trials where you're trying to use it in combination with something that would impair the cell's ability to repair its DNA. And then these are these immune therapy things that are so important for other cancers like colorectal or melanoma or renal cell. Obviously, we would love to just discover their relevance in neuroendocrine, but that we're not quite there. So I think that's all the thing. So I am actually not going to talk about histotripsy other than to maybe pour, this is going to be like, Phil's going to be like, is she going to get on her friggin' soapbox? Is pour a little bit of cold water on this. Histotripsy is an awesome non-invasive thing, and those were really cool pictures. And you guys will have it available in Nashville. And for the question that said, where are the histotripsy available? There is a site, Histosonics, that can give you a physician locator depending on where you live. But in neuroendocrine, we have a lot of really good liver-directed therapies. It's only FDA approved for the liver right now. And so you kind of have to say, oh, well, the catheter-based techniques that Andrew Marsala has, ablative and stuff like that, it's tried and true. It's been around for seriously 50 years. And so I think that yes, those things are more invasive. Yes, we have done many histotripsies on neuroendocrine, but that we have to look at it tempered. We don't have that much data. With Vanderbilt coming on board, between Rocky Mountain, us, and Vanderbilt, will probably very quickly get a lot of patients with neuroendocrine and be able to answer some of those questions. But that also immune modulation therapy in a lot of neuroendocrines has also not been that relevant. And so we have yet to be able to show that the immune response is stimulated. So the idea behind something where you can treat one thing, you can treat Bob and cripple Bob, and in the process of crippling Bob, you cripple all of these tables over here. Oh yeah, that seems really great. That's called this abscopal, or this immune response. But the issue is that we have not yet shown that in neuroendocrine. I am so hopeful. I think our early data suggests that we had a patient that had refractory carcinoid syndrome, rescue doses of the thing, didn't even have progression, but he had something hotter than hot in the liver. He was just like, I want histotripsy, like nothing else that we could do. He was like, I want histotripsy. So we treated him with histotripsy. There are some nuances to neuroendocrine because on ultrasound, they can be a little bit difficult to see in the liver because the background liver noise looks a lot like tumor. So we're using fused images. I think we've gotten a lot better at how we target that beam. So our ability to treat tumors, unequivocal, like no doubt in our mind. But that one patient, we shot that one tumor. That was our whole goal. That one tumor, even though it didn't really look that different on his on his post-procedural imaging, not like embolization or ablation, but his serotonin dropped by 50%. He went off of rescue shots, and he's like 3 or 4 months out and didn't need any rescue shots in 4 months after needing like 3 a day. So you kind of look and you say, well, that's kind of cool. But we don't know whether or not that's because he's getting an all over body immune response. So it's better able to do. And so you have to remember, PRT also is potentially associated with that same sort of immunity type response. So it's not just histotripsy, but it is definitely. So most of the immune response data in histotripsy has been in metastatic colorectal, which is really great for the people with metastatic colorectal because that is really very challenging to treat. So, and then irreversible electroporation. And the only reason I bring up this is that it just looks like an ablation probe. Andrew Marsala showed you the thing, super duper easy. Obviously, it's minimally invasive because you have to push that probe, in there. But the reason why I'm bringing it up is it's also associated with this weird immune thing. So the immune response is that you will hit something, you will blow holes in the pore of the membrane using electroporation, and the goop, weeps out of the cell, and then it exposes all these tumor identifiers, and your immune system's like, what the hell is that? It then develops an army around that tumor specific thing, and then it's going to attack anything that looks like that. And so the idea that you would be able to hit one thing and then have other things that it's amazing, but it's not limited to. So a lot of what we do, PRT in neuroendocrine, PRT, irreversible electroporation, which is electroporation blows holes through the membrane, and histotripsy, cavitation, meaning it just implodes on itself like a bad cake in your oven. All of those are associated with the same sort of gooey, weepy things where your immune system is likely able to identify it. We are trying in our program, and then we can collaborate with Vanderbilt. We are trying to do one of those. It's going to sound like Theranos, but it's not. Something where it would be a drop of blood going onto looks like a glucose strip thing, and we would able to do a really, really simple immune test that you could easily do, like even actually probably in your own house, but that at your follow-up visits without getting a blood draw. And we would probably be able to look at the systemic level. Maybe we aren't seeing it on the imaging, but maybe that's because neuroendocrine, everything has it. It takes a long time because we don't really see it with PRRT either. So maybe it's just we have to wait longer to try to see some of those immune responses. And I think we're going to come up with a way for us to test it, give us a little bit more evidence that it is relevant, that component is relevant, because then obviously we'd probably be doing even more of it than if we thought that we could hit one tumor and then have that affect something that is outside, like in the bones or the chest. Okay, I think that is it. Sorry. And that's just me telling you. Oh, that's just the summary. Standard of care option, timing of treatment along the disease continuum is not absolute. It's most relevant in patients with multi-organ site, and then the emerging data on using it in combination or earlier in time course. Oh, and then these are the thing, if people want to just, is if you use those are the videos that we do, of which literally, since we all work together for Life Fires, so you'll see a video with me and Rob, and me and Andrew Marsala, and me and Phil Boudreau, and we did all these Facebook Lives that went over all of these different, things. Okay, thank you very much.
Okay. I want to remind you, don't forget to write down your questions. It's the same thing as the morning. We got 2 more presentations to go. So why don't we take a... Ramirez right now. So come on up, Rob, and we'll do a break afterwards. That's because the hotel didn't put the break out yet, so. Sorry, Rob.
I was looking forward to my break.
Yeah, well, you'll get one afterwards. That's
Okay. All right, we're getting towards the end. Everyone hanging in there, okay? So, all right. So, thanks again, everyone, for coming. Hopefully you've gathered a lot of information. I'm looking forward to the question and answer session at the end. So I'm going to talk about neuroendocrine tumors above the diaphragm. And so I have a interest in lung neuroendocrine tumors. So that's what we'll talk about. And they're different than the neuroendocrine tumors of the GI tract or pancreas. But they are very diverse. So we call these things pulmonary carcinoid tumors or neuroendocrine carcinomas. So depending on where they fall on that spectrum, there's some risk factors. We think about smoking, lung cancer, it happens in smokers. Well, not always. So sometimes the higher grade malignancies, the small cell lung cancer and the large cell neuroendocrine carcinoma, these are diseases of smokers. When we talk about the lower grade ones, there's not really a whole lot of risk factors. There are genetic syndromes. So I mentioned earlier MEN1 and MEN4. These can predispose to these, but a lot of times these, there's no risk factors. And I see patients from, this disease really does not discriminate. My youngest patient was 11 when he was diagnosed, and I have very elderly patients and everyone in between. These are pretty uncommon. Okay, so the pulmonary carcinoid tumors are the lower grade neuroendocrine tumors of the lung. They represent about 2% of all lung cancers. So when you go to your general thoracic oncologist, this is really just a minority of what they see. But when you go to a NET specialist, this represents about 25% of all neuroendocrine tumors. So you're gonna, the NET specialists in the room, they see more and more of this, and I think people are starting to recognize that. Lung nets are increasing in incidence. So this is a graph of actually all neuroendocrine tumors by site. In general, neuroendocrine tumors are increasing, but the one that is increasing the most, this is lung right here. So we see, we're seeing more and more of this, and I think, some of it is is it truly increasing, or are we just becoming more aware of things, and or do we have better imaging techniques, or are we just imaging more? You go into the ER for a stubbed toe, and next thing you know, you're walking out with a CT of the chest, and we sometimes find these things. So okay. So some of the symptoms of the neuroendocrine tumors of the lung vary. So, a lot of it is respiratory, so recurrent pneumonia is, I see a lot of patients who have cough. They can sometimes cough up blood, trouble with the breathing, wheezing, chest pain. And again, a lot of these things are diagnosed incidentally. There are some hormonal syndromes that can come along with this, much less common than when we think about the carcinoid syndrome in patients with the small bowel tumors, or even some of the pancreas tumors, some of the hormonal syndromes that can come along with that. But we certainly can see this. So we'll check for certain hormone levels depending on the symptoms. So this is a CT scan of a patient, 45-year-old woman with an incidentally found lung nodule. So what we're looking at here is a cross-section through the body here. So this is the left side, right side. Here's the heart. The black things here are the lungs, and here's that tumor. So that is a very abnormal scan. So what do we do when we see that? That could be, we think about, all right, what are all these options that this could be? But it definitely needs to get worked up. And it all starts with a biopsy. And some of the things we talked about, Dr. Gupta talked about, some of the things we look for when we look at this underneath the microscope. So a differentiation status that tells us how does this look like? What does this look like compared to a normal lung tissue? The mitotic index, how many cells are dividing, in the Ki-67 proliferative index. So this is again a marker we put on the slide when we look at this underneath the microscope, and it gives us an idea. A percent of the dividing cell goes anywhere from less than 1% all the way to 100%. And the folks who are over at 100, 80, 90, 100%, very, very fast growing cancers. So there are some neuroendocrine specific labs, again, if depending on the symptoms, and then imaging, and then pre-surgical evaluation with pulmonary function testing. So tissue is the issue. That's there's an old saying in oncology: no meat, no treat. And so we really need to know what we're treating. So it all starts with a biopsy. We have you've heard over and over and over again today about our multidisciplinary approach to things. And so for the lungs, it's a little bit different. We have so at Vandy, we everybody's very siloed into what they do. So I go to two different tumor boards. I go to my neuroendocrine tumor board, and then I go to my thoracic tumor board, because usually the thoracic people don't, the surgeons, the chest surgeons, they're not at my neuroendocrine tumor board because they're operating on non-small cell lung cancers, so I go to these two different tumor boards, and thoracic is a little different. So we have our pulmonary folks and our thoracic surgeons and radiation oncology. So we all sit down and we look at pictures and come up with the best way to get a biopsy. But there's different ways to do a biopsy. Dr. Marcella, he showed you some pictures about some of the things that he does. But there's when you're in the lungs, you can do some of that. You can put a needle through the chest wall and do a biopsy like that, and he does that quite a bit. But a lot of times we'll do this through a bronchoscopy. So this is a procedure where we put you to sleep and actually take a tube with a probe, put it down into the windpipe, into the lungs, and we can actually use an ultrasound probe and actually visualize the tumor or lymph nodes on the other side of the wall and put a needle through there. And I've got a picture of that. This is called endobronchial ultrasound. Thoracentesis, sometimes patients have some fluid in the lungs. We can take a needle and either drain that fluid out and get that at biopsy. Pericardiocentesis is when there's a fluid buildup around the heart. Sometimes we send for open biopsies. So we send to our thoracic surgeon for an open biopsy. So this is just a cartoon of the chest, of the lungs, and some of the lymph nodes surrounding. So here's your left lung and your right lung, and all these little things right here. These are all lymph nodes. So how do we get those? Well, there's a procedure called a mediastinoscopy we sometimes use. We don't do this too much anymore, but we make a small little incision right at the base of the neck, and we can scope down there, and we can pluck out some of these lymph nodes. As I mentioned, nowadays what we normally do is this EBUS probe or endobronchial ultrasound. So that's just a picture of what that looks like, and that little needle can go right through the wall of the airway and get tissue for us. So we talked a little bit about, how these things, the grade 1, grade 2, grade 3 of the neuroendocrine tumors, the GI tract and pancreas, and they're all based on the mitotic index and Ki-67. You can kind of see, how, the reason it matters is because people with grade 1 neuroendocrine tumors generally do better than people with grade 2 or grade 3. In the lungs, it's a little bit different as far as classification. We break this into essentially 5 different categories nowadays. We say the slowest growing are what are called the typical carcinoids. So that's akin to the grade 1 neuroendocrine tumors, the GI tract or pancreas. Is based on mitotic index. So how many, when we look at the cells, how many are actively dividing, and also the presence or absence of necrosis. So notice we didn't even say anything about Ki-67. That comes more recently. So nowadays we're looking at the Ki-67 for this. And we call this carcinoid/NETs with elevated mitotic counts or Ki-67. So usually over 30%. And so this is this newest classification before we get to the large cell neuroendocrine carcinomas or the small cell lung cancers, which are the very fastest growing. So that's the pathology for lungs. But so now how do we image this? So we do our conventional imaging with CTs and MRIs, like Dr. Marcella had pointed out. We will always get an MRI of the brain if this is a small cell or a large cell neuroendocrine carcinoma. Those higher grade cancers, they like to spread, and they like to spread north. So it's always that's just part of the usual workup. If it's a lower grade tumor, we normally don't do that unless there's some symptoms that have developed. But we'll look at those dotatate PET CTs. There are 2 of them that we can order. The gallium-68 PET or the copper-64 dotatate PET. If it is a higher grade tumor, we'll get an FDG PET. So as you've heard over and over again, functional imaging, this detects the presence of somatostatin receptors. So on this side, this is actually what Marianne was talking about, the old Octria scan, and how it gave us these little fuzzy pictures. And if you squint and turn your head a certain way, you could say, oh yeah, there's a tumor right there. But here's the same patient with a dotatate PET, and you can kind of see how you see things so much better on the dotatate. So I was actually just talking to a colleague yesterday in Las Vegas. He called me up about a patient, and they don't have a dotatate PET capability where he's at. So he did an Octria scan. And it's just such an inferior, test. So if someone recommends you have an Octria scan, just go somewhere else go somewhere else where you can get a dotatate. There are some differences, between the copper-64 and the gallium-68. We know they're both superior to the Octria scan. They're similar as far as concordance, as far as picking up lesions. But the big thing, and I think a lot of us have switched over to using copper alone, is because it has a much longer half-life. So it's actually made in St. Louis, and we order it, and it comes the next day, and we've got all day to use it. Whereas gallium, we need to make it locally and get it into the patient very quickly before it goes bad. So copper has really replaced gallium in what we do. But there are some pitfalls from the PET imaging. So most of the neuroendocrine tumors express these somatostatin receptors, but some of them don't. So sometimes you get a dotatate PET and it's completely negative. Sometimes not everything on a dotatate PET is positive. So you may have multiple liver tumors, and only half of them have dotatate receptors or somatostatin receptors. So there's some false positives. It really takes somebody who who knows how to read this scan, because many times people will, especially when we first started this, we said, oh, wait a minute, there's uptake at the head of the pancreas. Do they have a pancreas tumor? Well, it turns out that's a normal, that's a physiologic or normal process on this. You can have uptake in the spleen. When I go through scans in the clinic with patients, I'll show the scan, and if we start up here and the first thing that lights up is the pituitary, and, we have to say, all right, well, that's normal. Other things can light up, some post-radiation changes, reactive lymph nodes. We pick up a lot of meningiomas, actually, but we also, pick up things that we didn't expect to pick up. So there is some variability between copper and gallium, and so we sometimes really need to go back and say, all right, well, I've had patients that have had gallium at some point and then went on to get treatment, and then we get a copper afterwards, and the copper says, oh, wait, it looks like there's different disease. And it wasn't necessarily progression, it just wasn't picked up on the gallium before. So, and we can't really rely on SUVs. So SUVs are the numbers on when you get your PET scan report, they'll say SUV max of 15, previously 12. You can't really rely on that to determine progression. You really need to look at sizes on things. So, and again, each patient really needs to be discussed individually in a multi-D setting. So this is the same diagnosis. So a big lung tumor here, PET positive, versus this one. So they're both typical carcinoid tumors, but we treat them very differently. You can see this one has a bone metastasis. So what do we think about when we start talking about treatment for lung nets? So again, this multi-D review, we got to look at stage. Is this an early stage? Can I potentially take this out and cure it, or has this already spread? What are the symptoms? Are there somatostatin receptors? So we always try to get a dotatate PET on patients prior to them going to surgery if we know about that. The bulk of disease, comorbidities, essentially lung function. So we get pulmonary function testing. Can they tolerate an operation? If I take out, unlike the liver, where you can, Dr. Boudreau showed you pictures of, a table full of tumors. If we had that table full of tumors in the lung, the patient's really going to be huffing and puffing when they get out of surgery. So we've got to, it's valuable real estate in the lungs. So we've got to be careful about who we operate on. And then obviously, looking at, patient preference. So generally for early stage pulmonary carcinoid tumors, we take them to surgery. Surgery is similar to how we would operate with a non-small cell lung cancer. Traditionally, we'll take an entire lobe, but we can sometimes get away with, especially with typical carcinoid tumors, less than a lobe. So we'll do something called a segmentectomy. We always look at lymph nodes and examine it. We always try to take as many lymph nodes as we can to really stage patients. If a patient does not want surgery or they're not a candidate for surgery, we can do very high doses of focused radiation, something called stereotactic body radiotherapy or SBRT. and that can essentially kill the tumor off. We do a lot of this in non-small cell lung cancer in those patients who have COPD and really bad pulmonary function testing. And as you can imagine, if we take out a lobe out of one of those patients, they're not going to do well because because they're not coming in with good breathing tests. So what we learned in that population is if we do this radiation, it's pretty much equivalent to doing surgery, except we don't get lymph nodes at that time. We're learning more and more about doing SBRT in the pulmonary carcinoid tumors, and it seems to be just as beneficial. Interestingly, in non-small cell lung cancer patients, if I take a tumor out and it has involvement of the lymph nodes, then we're generally recommending chemotherapy afterwards to try to kill off any other disease. In this disease, we do not give anything afterwards. The reason is we don't have any good evidence that it's beneficial. So we looked at all these different guidelines here. These are the NANETS, that's our parent organization, ENETS, which is the European Neuroendocrine Tumor Society, NCCN, which is a conglomeration of multiple cancer centers, including Vanderbilt, that come together and build guidelines for treatment of each cancer, and then ESMO, similar on the European side. And so at NANETS, I think it was in 2017, we all got together and said, patients with, the question was whether or not to give adjuvant treatment here. So we said adjuvant surgery without adjuvant treatment because there wasn't really much evidence. Everybody else said, oh, you got to give chemotherapy afterwards or radiation. So we went through and we actually published a paper and went through all of this, and we were able to get the guidelines changed for NCCN at least, and so now chemotherapy is no longer indicated in the U.S. for these patients. So these are the types of procedures you may see. This is, we look at things called a wedge resection, where it's simply that. You see I have a tumor sort of on the periphery up here, and we take a little piece of the pie and get rid of it. The more correct way to do this, something called a segmentectomy. So we take not an entire lobe, but a segment that the tumor is located in. We can do a lobectomy. A pneumonectomy is where we take the entire lung. We try not to do that because that compromises lung function. But if you have a tumor that's very, very proximal right off here, it's very tough to get away with one of the other procedures. There is a procedure called a sleeve where we can actually take out the part involved with the tumor, take out the part of the lung, and then put this part back together. So that's called a sleeve pneumonectomy. So in these, again, I'm not being a surgeon, I rely on the surgeons, and I'm sure they explain this a whole lot better than me. I mentioned SBRT, again, short doses of high dose radiation, usually given over a 5-day period. Pretty equivalent to surgery, but again, we do not have the lymph node data, so we don't again that sometimes prognosticates what we're gonna how close we're gonna follow patients. Okay, so this is just a paper that looked at SBRT versus what we call fractionated radiation. So a lot of times fractionated radiation is given lower doses over a long period of time rather than high doses over a short period of time. So it turns out that, as Dr. Maluccio pointed out, anytime you have this separation of the curves, that shows a very significant benefit, and that's what we see here with SBRT. So this is a patient of mine. She's 75. She has an atypical carcinoid tumor. She was you can see right here. She was not a candidate for surgery or decline surgery, so we gave her a week's worth of radiation, and so what you can see is that killed that tumor off. Interestingly, these things can sometimes occur within the airways. So sometimes patients will come in with trouble with their breathing or coughing up blood or wheezing, stridor, and we get a scan. And what we see here is right there. So that's the windpipe is in here, and this branches into the left lung and the right lung. So sitting right in the middle of that tube is a tumor. So what we can do for that is something called endobronchial therapy. So there's different ways to do this. We can freeze it, we can cook it, we can give it light therapy. But what it does is it kills that tumor off. And sometimes we can avoid an operation. So this is just a picture of a patient of mine that had this done. So you can see in the airway here, you see this tumor. They froze it. It's the cryotherapy, and that's what it looked like. Afterwards, they go back at 6 weeks, and so you see that airway is wide open. You may still have a little bit of tumor right here, so they froze it again, and then comes back at 8 months, and you can see it's completely gone. Oh, I had a, okay. So I have another slide that actually shows that same picture. I guess I didn't include it, this one. But essentially, we went back and did the same, looked at that same picture, but this thing was completely gone. And this was he was 35 years old, and hopefully will not need anything else ever again, but we'll continue to follow. Okay, so what options do we have? Okay, so this is a 70-year-old patient of mine with typical lung carcinoid. Okay, so I mentioned slow-growing cancer, right? Typical. This is the slowest one, but you see how much disease this person has. So, well, sometimes we think about observation, and I'll talk more about that. We talked about some of the somatostatin analogs, radionuclide therapy, chemotherapy, immunotherapy, targeted therapy, liver-directed therapy. Do we do molecular testing? And obviously clinical trials. So who can be observed? Okay, so sometimes we can observe people if they come in and we know that this is a typical carcinoid tumor. If they're asymptomatic, they have a low volume of disease. And then sometimes I say, all right, have you ever had a scan before? I'm sitting there looking at a scan. Oh yeah, I had a CT, 5 years ago for something, and we'll track down that CT. And if it looks exactly the same as the CT that's in front of me today, that's someone that maybe I don't need to rush them off to get therapy right now, because this is, again, long documented stability of disease. But usually when we decide to start somebody on treatment who has advanced disease, so people we're not going to operate on, we talk about the somatostatin analogs, and we have two that we choose from, either octreotide LAR or lanreotide. So these are the two trials that really showed that this can prolong progression-free survival. So you can see this is against a placebo, and you can see this is octreotide. The latest one was the lanreotide study. So again, this is placebo. This is lanreotide, did much better. Problem is these things were not done in the lung neuroendocrine tumors. And it wasn't until this study where we really had prospective data to look at the lung neuroendocrine tumors. This was the SPINET study. It was actually just recently published, 216 patients they wanted, and they randomized patients to either lanreotide or placebo. Unfortunately, they did not, this was open for about 3 years or so, and they halted because of slow accrual. It was open worldwide. And we had this study open when I was in New Orleans, and I think we were the #1 enrollers in the country with 3 people. It was a very it was a very hard study to accrue to. So they actually ended up with 77 patients before they stopped it. 58% were typical carcinoid tumors, and it turned out that there was a degree of benefit for lanreotide, but it was primarily seen in those patients with typical carcinoid tumors, not the atypicals. So, so that was actually just published this year. It was actually presented, the data, in 2021, and it just came out this year. So, so that's an option. The only FDA-approved therapy, FDA-indicated therapy for lung nets is actually everolimus. So this is what we call a targeted therapy. So this inhibits the mTOR pathway that the cancers use to grow. So this was actually based off of this RADIANT-4 study, which looked at patients with neuroendocrine tumors in the lung and also the GI tract, and randomized them to either everolimus or placebo. And it turns out that the everolimus did much better than placebo. So that led to the FDA indication for everolimus for lung nets. Doesn't mean that we don't have other options here. It just means that's when you look at the package, they say that's what this is. That's what this is indicated for. So the latest data comes from a study called CABINET. So this looked at a drug called cabozantinib, which is another oral agent. And they looked at two different patient populations. So they said pancreatic neuroendocrine tumors and extrapancreatic neuroendocrine tumors, so including lungs. So they randomized to either cabozantinib once a day versus placebo, and what they were looking for is, again, this progression-free survival. So how long does this work for? The important thing was to look at with this is you needed to have prior treatment for your tumor. So this was not a first line agent. So in lungs, everybody needed to have everolimus. You can see out of all the patients here, it was a minority of patients who had lung nets. But again, it was one of these things. Lung nets is an understudied entity. So I'm really glad they included this because this may give us another option here, because what you see here is the cabozantinib versus placebo. So did much better. This is the extrapancreatic cohort. So not yet. This has been submitted to the FDA. This is what came out in the New England Journal 2 weeks ago. So we'll see what the FDA says, but this could be another option for lung nets. Now, Dr. Maluccio talked about PRRT. Okay, so I won't belabor this. This was the NETTER-1 study where they looked at patients with mid-gut neuroendocrine tumors with Ki67s less than 20%, who were already on octreotide or lanreotide and then had growth on that. So they randomized them to either PRRT versus high-dose octreotide, and as we saw earlier, the PRRT was much more impressive. Response rates 18%. It doesn't mean that so when you read our papers and we say response rates, it doesn't mean that only 18% of people benefited from this. What that means is 18% of people had shrinkage of their tumors by 30% or more. So it's a very strict definition. So I often tell patients before they get on this, I say, all right, if I get a scan on you when you're done with your treatment and it looks exactly the same as the scan prior to the treatment, that's a good scan. It means this treatment worked, because you got to remember that disease was growing before you came in. So we've stopped it from growing. Obviously, we like to see it shrink, but that's not always the case. So if we have stability of disease, sometimes that's just as good. again, this was in midgut nets. So we don't know how this works in lung nets. This is the NETTER-2 study. This is in the higher grade, first line neuroendocrine tumors. Again, this is neuroendocrine tumors, the GI tract or pancreas. So we don't, there were no lung nets in here. So we don't really know. In a prospective fashion, there's a lot of retrospective literature that says, oh yes, PRRT works for lung nets. And so you can see that we have response rates over here that are in the 30 percentile, 20 percentile, and PFS or progression-free survival. So we use it, and if we look at all of our guidelines, our NANETS guidelines and NCCN guidelines, if patients have uptake on their dotatate PET CT, this is a tool that we use. How do we sequence therapy? We actually have this trial, which is open at Vanderbilt, which randomizes patients to either PRRT or everolimus. And so we're trying to figure out, all right, which one do we use first? Are they equivalent, or is one superior? People who will get on to everolimus, they take this until they progress, and if they progress, then they can switch over and get the PRRT. So this trial has been ongoing. It's a nationwide trial, so we'll have data in hopefully several years that'll give us an idea what to do. So does chemotherapy work in neuroendocrine tumors of the lung? Well, in some, I think. So when we think about some of the high-grade neuroendocrine neoplasms, small cell lung cancer, large cell neuroendocrine carcinoma, chemotherapy is the backbone. Okay, and we try to, this is looking at cisplatin and etoposide, and that's our general, this what we generally do, and combine it with immunotherapy for these higher grade tumors. With the lower grade tumors, it's much different. So this is actually a lot of older studies because we really don't use this anymore. We've got other tools that we use. So this is IV chemotherapy. It can certainly come with side effects. If someone comes in with a typical carcinoid tumor, I'm never using this on them. So what I will use is sometimes a combination of capecitabine and temozolomide, which is a regimen called CAPTEM. So we think about this in some of the pancreas tumors, which shows benefit, but in lung nets, it also seems to confer benefit. So this was a study that looked at only 33 patients. In the lung net studies, you won't see very large studies, but most of the patients were atypical carcinoid tumors, and it looked like they derived benefit, so a median PFS of 9 months with an overall response rate of 18%. So similar as to NETTER-1. So it has activity. It's something when I don't have tons and tons of things that in my toolbox, this is something I'll go to. This was another study that looked at lung nets from 2008 to 2018. This is 20 patients out of Moffitt, and they saw a 30% response rate and stability of disease in 55% of patients. So with an overall disease control rate of 85%. So I think it works. I think there's a study that's going to be opening that's actually an international study that's looking at patients with lung net patients who've been on CAPTEM. So we'll be participating in that, and maybe that'll give us a lot more information on the role of CAPTEM in lung nets. What about immunotherapy? The whole world is abuzz. There's about immunotherapy. So you see all the commercials on TV about Keytruda and Opdivo and other immunotherapies. Well, does it work in the neuroendocrine world? The short answer is there's not been very good studies that show immunotherapy does much in the neuroendocrine world outside of small cell lung cancer. But there is a little bit of data. So the keynote studies, those are the Keytruda or pembrolizumab studies. Low response rates, 12% in carcinoids. There was another drug called spartalizumab. Again, this is low response rates in the whole neuroendocrine cohort, so 7.4%. But in the lungs, it was north of 16. So, all right, well, maybe there's something different about the lungs compared to the rest. So sometimes I'll use this. Now, what I'll normally use is this regimen, ipilimumab and nivolumab. And this was looked at a whole cohort of 29 patients with 11 of them being lungs. Overall response rate of 24%, but it was 33% in the lungs. So again, something a little bit different about the lungs. So this is not necessarily on the guidelines, but this is something that when I get down to, all right, you've gone through the everolimus, you've gone through the cabozantinib, you've gone through the PRRT, you've gone through your somatostatin receptors. This is something if I don't have a clinical trial, this is something that we may end up using, and I've seen very dramatic responses actually with this. So it's, when we think about it, we don't necessarily, when we think about neuroendocrine tumors, we don't necessarily think about immunotherapy, but maybe we should. Essentially, more research is needed. This was actually an abstract we presented at NANETS a few years ago that actually looked at the number of abstracts in major meetings. We picked two major meetings. One was the North American Neuroendocrine Tumor Society annual meeting. The other one we picked was the World Conference on Lung Cancer. And we said, all right, well, how many abstracts pertained to neuroendocrine tumors of the lung, or not necessarily all neuroendocrine neoplasms, but the pulmonary carcinoid tumors? And it turns out that out of the total number of abstracts at NANETS, that's the number that had included pulmonary carcinoid tumors. In the World Conference on Lung Cancer, this went back to 2013, I believe. So several thousand abstracts. This is what we found out for this. And when we looked at primary clinical trials, 1% at NANETS only. So this was actually, this was 3% out of all trials in progress anyway. So, and the majority of these things were actually single institution studies. This is our data we've done. I saw 100 lung nets at my institution, and this is what I found. So not too helpful as far as driving the field forward, but certainly more research needs to be done. And I always encourage companies to include the lung nets in their protocols. So I'll conclude by saying that the lung nets are uncommon in, as we've talked about, do need a multi-D approach to care. The treatment is based off of stage, grades, symptoms, and we always, have this discussion with patients and see what their wishes are. There are a number of treatments. We don't have 30 different drugs for this, but we do have a number of treatments. And again, they do remain poorly understood and should be included in net protocols. So I'll stop there, and thanks for your attention.